Calgary. And with me, Deb Toole is from Children's Hospital, and really it's been instrumental in inviting me into this process around transitions. I'm hoping Terry Smith, our emergency department manager, might be able to join us to add his perspective of how our project is working from his perspective, but he hasn't joined us yet, so we'll carry on. I also have with me Candace Menzies. She's our patient family support specialist who really is the key to our program here at the campus. And I have a couple other colleagues, Valerie and Melissa, who just wanted to hear what we're doing here at the campus as well, because they don't even know what we're doing yet, because we're still in pilot mode. Just very quickly, South Health Campus is a relatively new hospital. It's an adult acute care facility here waiting in the southeast of Calgary. We started opening about 1.5 years ago. So we're a fully commissioned site now. We're just around 300-bed inpatient facility. Majority of that is adult inpatient. The only youth or adolescent inpatient component we have is a mental health unit. Everything else is just an adult facility. But we also have a very large ambulatory component. We have over 90 ambulatory clinics, see over 200,000 ambulatory visits per year here. So an integrated site. Hopefully that gives you enough context about South Health Campus. We're a brand new site. We're the only site in Alberta, other than the pediatric sites, that have a dedicated patient and family centered care program, which I think is really what made us unique and gave us that advantage and almost a launch point for Deb and I to have some of these conversations and start a pilot program down here. Okay. So we have a project down here. We are in pilot phase, and we're calling it an Adolescent Transition In program. Really what we wanted to do is just make it easier for those, for the very complicated, complex patients as they're making their transitions into adult services here at this site specifically. So we've defined these as medically complex adolescents who are transitioning from the Alberta Children's Hospital to adult care and may require emergency and or inpatient care at the South Health Campus as they become adults. And we do provide the definition of that medical complexity is those patients who have one or more chronic clinical lifelong condition that are severe and associated with medical fragility, high morbidity and mortality rates. They have very intensive care needs, going to have typically severe functional limitations, may require assistance from tracheostomies, feeding tubes, wheelchairs, that sort of thing. So probably a similar definitional framework that you are already familiar with, so I won't go too much into those details. So it's really those really complicated folks that we're looking at. DIMAR is the name of our database here in Alberta, where we track some of our patient statistics, and some of that data that Deb was able to mine suggests that of those really, really complex, the ones that would benefit from this type of transition program that we're developing, it's only about 15 to 20 adolescents per year that we feel would be candidates for this. But again, we're in pilot and we're going to learn if that's an accurate assessment at this point. This is a very complicated diagram. It's a bit of an eye test, so apologize for that. I'm just in the process of animating it, so it would come up one piece at a time, but I'll just walk you through it. And it's something we use to actually paint the patient's and the family's perspective of system navigation. Because with these families, they're not only transitioning their medical care as they start to become young adults, but they're also transitioning a whole lot of their other care. So over on the left-hand side in the blue, really that's a lot of what patients and families are navigating in those early years when they're children. So we've got educational systems, financial systems, the community agencies and the support, all their family supports. And then down at the bottom in the left corner is that pediatric medical system. And there's all the different levels of that. As you move over to the right-hand side, when they start to become young adults, we're not only transitioning, as I said, that all of those medical components, but they're also going through a lot of those other transitions at the same time. Particularly, their funding models change. Certainly here in Alberta, it's a completely different funding model of how children with special needs and complex medical issues are funded. They're transitioning into employment or volunteering or community support organizations, what the legal ramifications around guardianship, trusteeship, and all of that is changing. So in addition to all that complexity going on with what the families and the patients are transitioning, now we're asking them to leave the warm blanket, the care that we've been provided within our pediatric children's hospital environment and our specialty services, and we're asking them to move to adult care services. And I think that's fairly similar across the country. Our pilot project is really focusing on the acute care and the emergency types of visits. We're not yet delving into all of the subspecialty care. Most of those programs already have some type of transition in terms of how they transition patients over to neurology services and so on and so forth. We'll likely end up branching into that, but right now we're just focusing on what's highlighted in yellow there for the pilot, is that acute and emergency care type of visits. So hopefully that helps paint a little bit of a picture. So the goal we set out for this program was really to assist these patients and their families with system navigation and coordination of their services as they make that transition. And further broke that down into some more detailed objectives. Really, we want to help prepare the adult acute care site to manage these complex patients a little more comprehensively and help to transition or transfer important health care information between the facilities. It's that knowledge transfer to increase the competency and the confidence of the care providers. The engagements and confidence building of the patients and families, absolutely, during this process, how we can help with that. And really what we're finding, it's also about building those stronger connections between the pediatric and the adult sites so that our pediatric providers will be more confident transitioning and will have that confidence to let go, knowing that those bridges and that those transfers have taken place to support their patients as they let go of their patients who they've been caring for those 18 or so years. The next slide just gives you a view of who we have engaged in the project thus far. So a number of folks over within our children's hospital program, a number of people here at our South Health campus. So as I said, I'm with the Patient Family Centered Care Program. Candace and Melissa with our Patient Community Resource Center, Terry from Emergency. Transition Services has been helping us through this and looking at different opportunities. Neuro, we have lots of neuro patients go through those transitions, allied, even our registration admitting how we transfer the health records. And then we've been engaging some of our community pediatricians, pediatric home care, advanced care planning, and had some QI folks helping us out along the way. So we've had an awful lot of folks engaged to this point, and there's still more opportunity to engage more of them, and more of them keep asking about the project, even though we're still trying to keep it under wraps in pilot mode. We went through a little bit of a view and took a quick look at what are the needs of the health system. Here in Alberta, part of our Alberta Health Services Strategic Direction Plan is to develop service models, and there's a real focus to address the complex high-needs population, specifically patients with multiple chronic conditions, and they have highlighted the high-needs children and youth in that, so that we know this pilot and potential program is going to be supporting that in our strategic direction for the province. But also to prepare, I guess similar to the goal, to prepare the acute care sites to better manage these patients, to facilitate that knowledge transfer. We know we can provide better quality, safer care if some of these pieces are attended to. But we also, as a health system, need to understand and have what the expectations of our patients and families for what sort of family-centered care services they do expect when they get to our adult site. So it's an opportunity to learn what their needs are as well.
And what the pediatric providers' needs are basically an increased understanding and confidence in the adult healthcare system. I think Joanne has already alluded to that. But what pediatric providers want most of all is continuity of patient care. They want to know that their patients are going to be as well cared for in the adult world as they have been in the pediatric world. And so our hope in bringing them together and establishing some of that collaboration and communication piece is to develop that greater confidence. And you know, I guess the other thing that I'm finding in my work with pediatrics is that pediatric providers have had long relationships with most of these children, and they are very attached to them. And so letting go of them can be very difficult and can cause them lots of grief and loss, you know, as they leave the clinics. I like to throw out the question at this point: are there other pediatric provider needs? Are there other pediatric provider needs? Are there other pediatric provider needs? Are there other pediatric Okay, so and maybe that's a question that we can talk about later. If there's pediatric provider needs that we've missed, we'd really like to kind of incorporate them into this. So the patient and family needs that I hear from patients and families all the time is that they want uninterrupted, developmentally appropriate, and coordinated care. They want their care to look the same in the adult world as it does in the pediatric world. And they need assistance with navigating a very complex adult world, as well as a way of alleviating some of the anxiety and fears that they might have about the transfer to an adult acute care site. So if we have patients and families that are online with us today, it would also be good to hear from them in terms of, are we missing any of the patients and family needs on this slide. As part of the project, we also kind of looked at the research and the literature. Most of you are healthcare providers, so you're in the pediatric system, so you're probably all aware of the points in this slide. It just shows some of the common themes. Adult healthcare providers may be unfamiliar and uncomfortable with nonverbal, medically fragile patients that have complex care situations. A heavy onus is often placed on parents and guardians for some of that knowledge transfer and information exchange. But we also read and hear from families and read in the literature that their expertise may not always be readily accepted by the adult healthcare providers. There's also a substantial reliance on families and guardians for care during inpatient stays at adult acute care sites. And of course, the different cultures of care between pediatrics and adults, the difference between patient-centered and family-centered care, which often leads to the concern about whether or not parents and care providers will be allowed to engage in care planning or even welcome to participate at their level of expectation. Currently, this project is, as we've said, in the test or pilot phase of kind of a plan, do, study, act cycle. So basically, we're testing with a few patients, gathering some feedback, going to refine the process before we implement it on a larger scale. But Joanne's going to go into this in a little greater detail towards the end of our presentation. So at this point, I'll just note that the program is really only, again, for those medically complex adolescent patients, as Joanne has defined them, and it's not intended for our subspecialty ambulatory clinics. This is our patient eligibility criteria. They have to live within the vicinity of South House campus and be likely to present there for their emergency care. And these are our identified referral sources. Of course, the primary care pediatricians or physicians, my adolescent transition program, the ambulatory clinics at Alberta Children's, our pediatric palliative care service, also called Rotary Flames House, our pediatric home care, and of course any of the ambulatory clinics here at South Health Campus can also make a referral, as can their social work and emergency department. These are just some of the documents that we created as part of this process. We created 4 documents actually, and these are just 2 of them. And these are our knowledge. These would be our knowledge exchange forms. The first one, the one on your left, is the referral form that gets sent down here to the patient and family support specialist. And then the one on the right is the special patient communication, which is designed to share specific patient information and is specifically designed for the emergency department so that they can see some of the specialized burdens of this population. I know you can't read these documents, so if you like them, just let me know and I'm happy to send them to you.
Again, another eye test document. We always like to throw these ones in on slide. Really just to show that we did go through a process kind of to map out what this would look like. So it does start with the patient and the family through the referral source. And then really the important line where you can see where all the boxes and all the work is in Candace's role as our patient and family support specialist, really receives the referral, connects with the families, and then sets up all of the various appointments and meetings here at the campus when the patients and the families do come down to the site, and then the different departments that they connect with take over at that point. So what happens during an actual transition in visit? So this really simply shows it's really not a complicated process. We welcome them to the hospital. We give them a tour of the hospital. It's a brand new facility. Most people have not been here yet, and it's like a big mystery still here in Calgary, so people are nervous about it but excited because they hear all these interesting things about this new South Health campus. So we give them a tour of the site so that they get familiar with all the different amenities around, because they're used to different amenities at the Children's Hospital. This is very much built on a family-centered care model for our entire site, so they start to become comfortable quite quickly here at the site. If we have an empty room, which is really tough during flu season and when we're in bed crunch issues, but we try to make available a tour of an inpatient room. 90% of our rooms here are private at the campus, and they also have a sleeping area for a family member or a support person. And so that applies to all of our adult patients, so that immediately families say, oh, these rooms look just like the ones at the Children's Hospital, and my mom or my care worker can stay here in the room with me, and there's a space for them to sleep and so on. Again, hopefully we can make that available to just about all of our patients to see those rooms, because it does have a big impact. Some of the patients, if they have in the past been frequent users and visitors to the ICU, we can facilitate that. Our ICU manager and their team is very supportive to touring families through ICU. They have a meeting with the patient and family support specialist. Candace has a role where she can assess their needs, help them navigate, and just be a connecting point ongoing here at the campus for them, and also community resources. And we can also identify if they would benefit from other meetings with social work, with a spiritual care provider, or with any other services kind of other than their ambulatory specialty clinics. We're not going down that path with them yet. And then the key thing that happens during that visit is a meeting with our emergency department manager and one of our emergency physicians. So far, our medical director for emergency is taking the lead on this. And unfortunately, Terry hasn't been able to join us. So really what they do in those visits is they exchange that key information that Deb was pointing out on that previous form. So they exchange key medical information, key medical history, key medications, equipment needs, any special things that should this patient present at emergency. These are the key things that you need to know. So they're able to instantly get that information into our electronic records here, so that we now have a medical record created on site for that particular patient, even though they haven't already presented themselves in a true emergency or acute care visit. So we've got their key information. We know who their key specialists are back in the pediatric world, and who could be reached on call in an urgent situation. So that information is all being exchanged during that visit. And so ED creates that patient record, and we now have it here on site at the Children's, because we can't access their full chart from the Children's in any quick fashion. So hopefully that paints a quick picture of what that looks like. So we've only piloted this with one patient so far. So we're hoping to do 3 or 4 more and just learn and tweak our processes. So we received a referral. We started this back in October, held our first visit. And you can see kind of all the different folks that they met with. this particular one, we identified additional communication needs and follow-up, so there was some back and forth. But the fact that they built a relationship with our emergency department manager has just done wonders to increase that family's confidence, and I'll let Deb speak to that just a little bit. But they came back later for another visit, and we were able to arrange a tour of an inpatient room and just increase that relationship building and their confidence at the site. And we've also now done a feedback survey with them, so I'll just let Deb speak briefly to some of their feedback that we've received.
Yeah, their feedback was very positive. Their feedback indicated that they are significantly less fearful and anxious about bringing their child here for an emergency visit. Their child has an adrenal insufficiency, but also has temperature deregulation. And so they were very, very, very concerned that they would show up at emergency, and emergency would not recognize how sick she really was. And so I think it's given them immense relief to actually have met the emergency department manager. And
Danielle, please return to the unit.
There's obviously something about me. As having met the emergency department manager, and I believe he was actually going to give them some sort of triage letter so that when they came in, the triage process was quick and smooth, and they didn't have to spend a lengthy time in the waiting room, given the fact that they wouldn't come in unless their child was very, very ill. And so they are way more confident. At one point, they were not even willing to leave the children. They were requesting that they could stay at the children's for the next, at least a year, but they would like to stay there for forever. And so they've been able to move over here, and they're more confident.
So this really quickly shows just our timeline. We're still in that pilot phase. We're hoping for 3 or 4 more referrals over the next month or two, and then we can continue to evaluate, and we're collecting feedback from the emergency department and everyone who's involved in the process, as well as the patients and the families, so that we can further tweak, go through these PDSA cycles and just kind of make sure we've got everything the way we need it, and then develop a communications plan. So we hope by April we're ready to roll out, because really at that point we need to start communicating this with the 40-plus pediatricians throughout the city of Calgary, as well as some of our ambulatory clinics at the Children's and our specialists that this process exists. Our caution is always it only exists for patients coming to South Health campus. So we're constantly being asked, we have 3 other adult acute care sites in Calgary. Can we move this over to those other sites? So we just want to make sure we get it right here before we start to engage in conversations with the other sites, and we would certainly hope that we will be able to do that. So that's where we would move into the 3rd phase of sharing this and hopefully spreading it throughout at least Calgary zone, and certainly if the rest of the sites in the province are interested in looking at what we're doing here.
Yeah, I'm going to just interject at this point. Just before Christmas, I had the opportunity to meet with the medical lead of our Foothills Medical Center, and he was very interested in this project. And so I asked him if there was someone equivalent to the patient family support specialist at their site who might be able to receive these referrals, and we might be able to implement something like this at Foothills, which is probably the largest acute care site that we have here in the city of Calgary, and it's also a teaching hospital, which I think South Health Campus is as well, right?
Yeah.
Anyways, and so that I am very hopeful that, if we can implement it here and get it off the ground and running successfully here, that there will be other adult acute care sites in the city that will be interested, and that then hopefully we'll be able to spread it throughout the province.
Yeah. It's almost feeling like we're going to be spreading it before we've even finished piloting. People are just saying, yeah, it's just the right thing to do. Let's just share it, and this will work well at the other site. So we're trying to keep it really simple for that reason. So really that's what we wanted to share, and we thank you for the opportunity to be able to share what we're doing, but we really would welcome any feedback or comments on it. I know Deb's thrown out a few questions. Have we captured the needs of providers and patients and families adequately in this? So I'll just leave it there and throw it open for any questions or further feedback.
Can I just ask a question? In relation to the chart flowing seamlessly from the pediatric care to the adult care, is that a separate quest that you have partitioned off from your main thrust? Do you have people who are working on that issue?
That was one of the biggest hurdles that we had with all of this, because the paper chart does not transition from children's to the site. We haven't completely resolved it. We've had some conversations with our health records people and our admitting folks, and we haven't completely resolved it, but we've certainly opened up the opportunity to say we need to start thinking outside the box to resolve it. One of the challenges is that even though this young adult may present here for their emergency and their acute care, and some of their specialty care, some of their other specialty care may be up at our Foothill site, for example. So they, just the way we're split up around Calgary, some of their specialty care may be at 2 or 3 different sites. So who's that home site going to be to own the chart, that sort of thing.
Which is why the chart stays at the Alberta Children's Hospital. However, through the process, the patient that we've actually piloted with, they came in with that special patient communication completed by their pediatrician. And then he also sent additional health information with them that they actually put on, created a paper chart here at South House Campus and actually put on. And then my understanding was that then the medical director would also have a conversation, or the emergency department manager, around what other documents they might need from the chart at the children's, and then put in a request for that information prior to the actual transfer of care. So for that patient, they were in October. If there were additional documents that the pediatrician didn't send with the family, they could actually submit a request, and then the Alberta Children's Hospital would make copies of that information and send it down to the chart at South House Campus once one had been created.
And this has to be so paper-oriented. It's not possible for there to be computer-generated charts?
Well, if we're on the same computer system, that's one of the problems with Alberta Health Services, is that, and between the transition from pediatric to adult care, is we don't always all use the same computer programs. So what the community pediatricians are using may not be the same as what we're using in pediatrics, may not be the same as what's being used in the adult acute care site. So they're not readily, our electronic records are not readily transferable.
Yeah. The key thing was to get the important information into the electronic system for the emergency department to be able to access quickly. And really that's what we identified as really one of the primary needs here. So we've been able to do that.
And so there's a signing off of authorization from the family and the patient that's making this transition for there to be ready access to the chart? That would be, I guess, a first step.
Yeah, the family can, that release of information, you mean?
Yeah.
Yeah, the family can, yeah.
Yeah, and really the key to this was getting our health records to agree that we could create a chart, an electronic chart and a patient chart here on site without an actual patient acute visit. Or a true emergency department visit. It's a meeting with the emergency department, but we treat it as an emergency visit, so they're able to create that patient record, and now we have a chart on site.
Okay.
That was the key.
Start at ground zero, like from that point on.
Yeah, so they treat it as a patient visit and emerge, they create the chart, and they discharge.
Right. Okay. So anything that's older, that's being generated in the care of the patient, has to be requested, but at least the file is open. There's a chart open, but they still need to make specific requests for what's happened in the past. Is that what you're saying?
Yeah, that would be accurate. That anything that happened in the past that the patient didn't bring with them, that they felt was important to have on the chart here, they would have to request from the children's hospital.
So that's a consult in and of itself, I would think, with the family and patient, with their next adult care, kind of focused transitional care provider, is to define what gap to be covered, what needs to be requested together.
Yeah, and I think for the most part, I think the community pediatrician who made this referral for this family, I think he sent all the relevant information, and the family actually had documents that the pediatric subspecialty clinics had given them as well. And so they brought all of those in. This is a family that's really good at keeping track of that health information. So they had binders of information. So for this specific family, the transfer of information piece, I think, was handled rather successfully. We have to pilot with a few more to, those who may not be as good at keeping track of the health information, to kind of see how that, transfer of health information goes. That will be the trickiest part, right?
Yeah, because, I mean, A, it's cumbersome, and B, to keep it always updated and take it with you.
Yeah.
Right? Yeah. It's a lot to expect a lot of people to be that organized about it.
Yeah. Well, what we do find, though, is a large majority of these really complex patients, the families have been so integrally involved with their care, they usually show up with the binder anyway. They've been carrying their binders with them for years, or they have access to that information. They're extremely knowledgeable. So they are, those experts, and they come with that expert information. The one other thing that is a real benefit, the fact that we're able to create that emergency record in our electronic system here, is should that child, or that youth, now that young adult, present at one of our other adult emergency departments, they can pull up that record now electronically, and they have all that key information. So if they were in another part of town, and that's where they were taken to, then they now have electronic access to that information.
So thank you.
To the chart that's been generated throughout pediatric care.
No, the new chart that's been generated at the adult site.
Okay.
Yeah.
Yeah, the adult site communicates well with each other. The pediatric and adults don't communicate as well, but the adult sites do communicate well with each other. So once we've done it here, that the record that's created in the electronic system for the emergency visit can be pulled up anywhere.
Right.